o'clock. We'll start. Good evening, everyone. I welcome, behalf of KCSI, I welcome all of you for this mortality, morbidity meeting. Today we have, this session is moderated by Dr. Ravi Shankar, Professor and HOD, Department of Surgery, Sagar Hospital, Bangalore, and Dr. Ellen Mohan, Professor, Department of Surgery, Vaidehi Institute of Medical Science. And the case will be presented by Dr. Nikita, first year DNB student in Sagar Hospital. To begin with, I request our chairman, Dr. H.V. Shuram sir, to give the welcome address. Shuram sir.
Thank you, Dr. Chandrasekhar. Yeah, I welcome all of you for this very interesting morbidity meeting, and really thankful to stalwarts, Dr. Ravi Shankar and Dr. Mohan, and also is our guest panelist, Dr. Lakshman, Professor Rajgopal Shana is there, so many other people. So let us have a very good, interesting, and discuss all the issues. Welcome to you all. Dr. Nikita, please start and you can share your screen. All the best to you.
Thank you, sir.
Okay, so I will just give a background of what. Thank you. At the outset, I would like to thank KCSI for this opportunity to moderate this session on morbidity and mortality meeting. Morbidity and mortality meetings form an essential part of the teaching armamentarium. I think if we move away from the rote learning, which was in vogue before, we should concentrate on knowledge base, which is gleaned out of experience of day-to-day management of patients. Morbidity and mortality meeting has been in world over accepted as a very good learning process and a standard teaching modality. It also forms an essential part of the curriculum of the national board, and I'm sure it also forms the part of the curriculum that is prescribed by Rajiv Gandhi University and all the medical university all over the country. There is an element of suspicion and doubt about what morbidity and mortality meetings brings to the to the fore. There is a suspicion that it is a exercise of blame game or finger pointing and and also targeting certain individuals in the department. I don't think that is the case. There is no blame attached. There are no punitive measures taken. It is a very it's a learning experience. It's a critical appraisal of the management of the patient from the outset. That is when the patient comes to you, whether it is through outpatient or as an emergency, and then assessment of the patient, investigations, surgical options and surgical management, intraoperative management, perioperative management, post-operative management, and discharge. So the entire process is critically appraised, critically reviewed to see, and it is done in a department with many consultants, professors, assistant professors, and teachers who are there. The purpose of this meeting is to go through a tooth comb of all the processes and procedures involved in the management of the patient, only to pick out problems that have arisen. May not necessarily be negligence or necessarily be a problem. It is just complications. It may be due to the disease factor, patient factor, and it gives an opportunity for the teachers to teach the youngsters, the postgraduates, as to what are the the critical points why they pick up before a complication happens. In the operative field, the professor or teacher teaches the students how they should be careful, and then in the post-operative management, how to pick up early warning signs and then handle the complication better before it happens or before it sort of becomes a very big problem which needs more intensive management in the intensive care. So the morbidity and mortality meetings are only a learning process. Again, when you look at Arthur Haley's final diagnosis, he says the dead teaches the alive. So when a complication which unfortunately results in death or mortality, one should critically look at ourselves to actually see what we could have done better, maybe to save the patient. It may not necessarily be a fault finding mission. It is only to get better and afford better patient care. So this is the purpose of a morbidity and mortality meeting. So I would gently urge, I'm sure many departments across the state are conducting this on a regular basis. It is a good exercise that all those who are not doing it, I would gently urge them to do that, because it is a very good learning process for everybody concerned. So with this introduction, I would now invite Dr. Mohan to say a few words before we start the case.
Thanks, Dr. Ravi Shankar. Again, thanks to Dr. Shivaram and the committee for giving me an opportunity to be here. I fully agree with whatever Dr. Ravi Shankar has said. And it is also part of the NMC curriculum. As you said, it's also part of the RGHS program, that audit meetings. We call them audit meetings, which also includes morbidity and mortality. Basically, audit is for morbidity, and mortality meetings are always held in the institutions across departments. The only other thing, as to add on to what Dr. Ravi said, it is not a fact sort of blame game or trying to find fault with someone. Is to correct the system and try and correct the process so that the end result gets better. So what is required is absolute honesty, because sometimes there is a tendency to hide facts, and nobody really learns if people start hiding facts or the truth. Because that becomes a problem. It doesn't serve the purpose. So it's important to be very honest and take it in good spirit. So these are the only things I want to say.
Thank you, Dr. Mohan. And I also would like to thank Dr. Lakshman for sharing his patient care with this, which is the subject of our today's mortality meeting. Over to you, Nikita. Start the presentation.
Yes, sir. Good evening, everyone. I'm Dr. Nikita. I feel honored to present today. I would like to thank KCASI for giving me this unique opportunity. It's an interesting case of pain, abdomen, and vomiting in a young female, which was managed by Dr. Lakshman. And today's presentation is moderated by Dr. Ravi Shankar HR and Dr. Mohan LN. So let's get to the case. At about midnight, a 20-year-old young female came to our hospital with the complaints of severe abdominal pain. It all started a week ago as a dull pain in the upper abdomen, which gradually progressed to severe pain for the last few hours. It was associated with retching and multiple episodes of non-bilious, non-projectile vomiting with food as content. It was in small quantity with no coffee grounds. It was since one day. She had no other GI symptoms and no comorbidities and no history of previous surgeries. She had consulted for the same complaints a day before elsewhere and was treated as a case of gastritis or food poisoning, and by giving her antibiotics and analgesics. But the symptoms did not subside, which made her seek our attention and hospital admission at that time of hour. On examination, she was conscious, coherent, and cooperative. General examination revealed tachycardia, tachypnea, and decreased saturation. On palpation, her abdomen was soft, non-tender. There were no signs of gourding or rigidity. And on auscultation, there was decreased air entry on the left side. Routine blood investigation and ultrasound of abdomen and pelvis, which were done outside, were reported as normal. So we admitted, our initial thoughts were gastric or high intestinal obstruction, biliary colic, and acute pancreatitis. So we admitted her. We have given IV analgesics, and her symptoms have reduced gradually, and she was planned for endoscopy the next day morning. It showed huge distended, dilated stomach and some holdup of food, and was distorted anatomy, which gave us an impression of gastric volvulus or pyloric obstruction. So we have inserted a Ryle's tube, normal saline wash was given, and Ryle's tube was kept open for continuous aspiration. Then we got a chest X-ray done of a PA view, and which showed a large gas bubble in the left thoracic region, and there was no gastric shadow, which was suggestive of stomach in the left thoracic cavity. But for the differential diagnosis, we also considered left hydropneumothorax, as there was right mediastinal shift. We immediately got a contrast.
Okay, wait here, Nikita. Any postgraduate students here? Postgraduate students, please volunteer, and can you read this chest X-ray?
Has it been posted in postgraduate group?
Yes,
Yes, it has been posted in the postgraduate group. Any postgraduates there are who would volunteer to read this chest X-ray, please?
For final year PGs.
Pavan, if you are there,
Yes, sir.
yeah, please read the chest X-ray. What are the findings that you can see?
Sir, this is X-ray chest PA view, sir.
Correct.
With the trachea, there is a deviation of the trachea towards the right side.
Correct. So it's a mediastinal shift.
Mediastinal shift is there, sir.
Yeah.
With the left-sided, there is left hydropneumothorax is there, sir. So with that is a large gastric air is there, sir, suggest of some gastric bubble thing.
See, how would you differential diagnose between, let us say, you, as you said, hydropneumothorax or a large fundic gas bubble or gastric bubble in the thorax?
Sir, in case of hydropneumothorax, so fundal shadow will be there, sir, in normal.
Correct. That is one.
And on auscultation, so we can.
No, I'm talking about the chest X-ray.
Okay, sir.
You will still see the lung markings, right? Even
Yes, sir.
there is hydropneumothorax, there may be some amount of collapse, but you'll still see the lung markings. Here, you can't see the lung markings at all.
Okay, sir.
So that is one other feature which suggests that it may be the stomach in the thoracic cavity.
Thoracic cavity.
Raj, sir, Professor Shanai, sir, anything to add?
No, sir. The student should know that diaphragmatic hernia is same thing. Whatever you said, no, fundic air bubble, left gastric bubble. If it is gone like that, there should be a reason why it is why it has gone up like that.
Yeah.
Partial gastric volvulus, mesenterico-axial variety, that is the volvulus of the stomach, which may be associated with the herniation into the thorax. So it could be a diaphragmatic eventration or diaphragmatic hernia. So these are the two things in addition to whatever has been told. These are some of the views. Okay.
Shivaram, sir, anything to add to the comment on the chest X-ray, sir?
No, I think Sangamesh has rightly put, there is spacing of the ribs. If you see that, the ribs are spacing. More than that, I don't think. So,
Ramakrishna, welcome. Your comments?
Sir, could it be acute gastric dilatation in a herniated stomach?
Yeah, because it is herniated. So that is the main thing. And probably it is, a volvulus because the patient, and depending on the endoscopic findings, and or it could be, acute gastric dilatation also. At this time, we can't say that there is no gastric dilatation. Lakshman, sir, anything to add to the?
They said passing the, sir,
Yes,
passing
yes,
the
Ram.
Rice tube was possible, no?
It was
Easily.
possible. Yeah, it was possible.
So in a valvulus or torsion, is it possible that?
It may still go, but it will, because the stomach will be dilated proximally, so it may still go into the stomach. Okay. So continue, Nikita.
So we immediately got an CECT of thorax, abdomen, and pelvis done, which
Yeah.
showed.
Yeah, no, don't say that. Sania, could you read this CT? Or anybody else volunteers also, I'll be very happy. This is a exercise for all of us, especially for the postgraduates. So I would like somebody to volunteer and talk about the CT scan.
Hello, sir.
Yes.
Sir, can you hear me, sir?
Yes, Indraja. Go ahead.
Sir, right side is CT, sir. So right side image, it is the transverse section, sir. CT thorax, which showing the air left side or hemithorax is occupied by the like a large air bubble with air fluid level, sir. And there are no bronchovascular markings on the left side, sir.
Correct. So what is your impression?
Ravi?
Yes.
Venkat here.
Yes, Venkat.
All these, no, everybody's reading these things. Nobody's mentioning that there is a huge mediational shift to the right side.
Chest X-ray, they mentioned it, but the CT they have not mentioned. You're right. They have to talk about the mediational shift.
So this should be an acute thing for so much mediational shift to happen. Otherwise, the patient would have come much earlier.
Correct. Indraja, there is mediastinal shift.
Yes, sir.
With the gastric volvulus and diaphragmatic hernia. So those are the findings. Mohan, anything to add?
Yeah, I just wanted to comment on the mediastinal shift as well. Even in the previous X-ray, it's very obvious, and the opposite lung is pushed dramatically to the opposite side, as well as the heart. And if you look at the aorta is in the center. But if you notice, the heart is pushed to the opposite side. So it must have been under a lot of pressure as well.
Correct.
So there's increased pressure on the left side of the chest.
Yes. Continue, Nikita.
Yes, sir.
Ravi, if I may point one thing out, please. If you see these pictures, there is something like a septum in the air bubble.
Yes.
And that shows a folding of the stomach.
Yeah.
Which would then rule out a simple gastric dilatation. Which is a possibility. It was a possibility before this, but once you see the CT, then because you see a septum-like thing separating the one single big gas bubble, you would then surmise that there is a fold in the stomach, which happens because of a volvulus.
Exactly. Right.
Yes,
right, Nikita, carry on, ma.
CT confirmed that it was a left bogdelic hernia with the volvulus of stomach, and the stomach extending up to the apex of left lung. It was an organoaxial volvulus. So we immediately planned for an emergency exploratory laparotomy. We went in with the upper midline incision, and we noticed that there was no stomach in the abdomen. It was entirely in the thoracic cavity. We tried to reduce the contents, but we had to give up as the hernia defect was very narrow, which was around 5 centimeters. So we had to extend our incision laterally, and we done a left thoracotomy and also enlarge the hernial defect. Then later push the stomach from the thoracic cavity into the abdomen. It was hugely distended. Upon derotation, we noticed that there was discoloration on the stomach. As you can see, this discoloration, we thought it was either a bruise or compromised vascularity. But as stomach is a very vascular structure, we thought we would give it a chance. So we decided on a relook surgery after 48 hours to assess the viability of the stomach. Then derotation of the stomach was done. Diaphragmatic hernia defect was closed by ethibond sutures, and thoracotomy was closed, and after placing a left ICD.
Okay.
So laparotomy, abdomen was kept open by laparostomy, and we packed it with gauze.
Okay. Now, Rajgopal sir, Would you
Yeah.
would you agree? Would you agree with the management so far?
Yes, sir. The patient has come as a acute, presented with the acute abdominal condition, number one, with a saturation of 93, as I understand. So the question that comes is now the stomach probably could not be delivered. Operating surgery is the best to decide on that day. The whatever defect of 5 centimeter which has been mentioned has been enlarged, and they were finding difficult. The reason may be volvulus with some edema more than anything. Stomach wall will have definitely edema here. So pulling definitely. Pulling means trying to probably insinuate the hands and pushing it down. It was difficult, yes. So thoracotomy has been done. Only issue is now after delivering the stomach in the position, yes, they're looking like little, some probably submucosal, some hemorrhage. Probably you can see that actually. So as of now, I think that is looking, because it's a very difficult decision at this stage, so it doesn't look like a case for resection at this stage.
Correct. Venkat, your comments on surgery so far?
No, whatever they have done, patient was in severe distress that needed decompression. But I don't understand why was laparostomy done.
Because laparostomy was done as a part of the damage control surgery, because the patient was very, on the table.
Let the PG answer.
Okay. Nikita, why did you decide on laparostomy? Why did you decide to not resect the stomach?
Sir, after reducing the contents of the diaphragmatic hernia, patient was in severe pulmonary compromise, sir, and her she was hypotensive, hemodynamically unstable. Hence, we decided for damage control surgery, sir. We kept the laparostomy open.
Correct.
No, Nikita, I just want to ask you one more question. Is there any other reason for this? Sir? Is it because patient was unstable? Is it because patient was unstable, this whatever laparostomy was done, or any other reason? You have written there, no?
Nikita, you have written there, what was the next step planned?
We planned for a relook surgery later. So
that is why it doesn't make any sense to close the abdomen if you are going to relook anyway. So it is one of the accepted management options in critically ill patients, and in where the vascularity of the said organ is in question, where a planned relook surgery is planned. Shrikant?
Totally agree.
Mohan, any comments so far?
No comments. The other reason, of course, is that closing the abdomen and the thorax would have taken a long time, and the patient is already quite sick. So this is a very quick procedure. So that is the other advantage of a laparostomy.
Yeah. Shivram, sir. Dr. Shivram, you have dealt with a lot of. Good evening, Dr. Habsur.
Good evening, sir. Good evening. Another reason I think so, Nikita, you should have mentioned, that is closing the abdomen with the diaphragmatic hernia repair would compromise the abdominal compartment, and this gives a space. Laparostomy gives enough space for it to accommodate the stomach properly. Correct. Because the stomach, whole of the stomach is inside the thorax. The abdomen cavity has become very small. So to accommodate that, you can always do this laparostomy.
Correct. That's another point. Very good point.
Very good point. Yeah.
Yes, Dr. Ramakrishna.
My question to Nikita, was there a role for conservative management? If endoscopy done and if you could pass a tube into the stomach and decompress it, and when the stomach size decreases, patient would have improved. Is there a role, something like that? My question to PG.
Nikita?
Sir, we had already done an endoscopy initially, sir. We couldn't decompress the stomach enough to reduce the hernia, sir.
And did you try putting a raised tube there inside the stomach?
Yes, sir. We already put a raised tube, and patient was decompressed using that, but it wasn't enough, sir.
Yeah. I think the CT scan was done after the endoscopy, no?
Yes, yeah.
Yes.
That also
Shivram,
shows
sir,
yeah.
you have done many difficult surgeries. What do you think so far? Any suggestions or?
No, excellent decision. See, patients, I think they have resuscitated very well and immediately investigated and took up for surgery when you have a doubt of the viability of the stomach. Stomach is one of the very highly vascularized organ. Still, if there is a doubt, and I think that's the appropriate procedure to do. And many times we do for small bowel, but stomach, it is very well organized, very well vascularized, but still it looks doubtful to the senior surgeon. Definitely, I think the damage control surgery is the best thing. Resuscitate, go after the planned hours, and then very closely observe the patient in the ICU and then take a decision. Sometimes we may have to go early also, or if the patient is very stable, we may wait a little more time also. So usually planned resurgery is about 48 hours.
Yes. Chandru?
Now everything is managed very well.
Is there a role for endoscopic derotation?
The gastric volvulus, I think when the patient is severely hemodynamically compromised, probably there is no role. If the patient comes to you with abdominal pain and vomiting, and then you do an endoscopy, then, but I have not seen the gastric volvulus which has with decompression and derotation that it stabilizes. Generally, it goes back to torsion again.
Sir,
so ultimately,
the main problem here is diaphragmatic hernia.
No, I'm asking. Was there anything?
Yeah, Dr. Lakshman may want to say.
Yeah, I mean the role for endoscopic management is in chronic partial volvulus.
Correct.
If you have an acutely ill patient like this with a major complete volvulus, as we have seen here, the gross dilatation, endoscopy will not correct it.
Correct.
There are, and of course, even in the chronic recurrent volvulus, if the patient is clinically stable and is, has minimal comorbidities, surgery is recommended. Only in the very elderly with major comorbidities, chronic, most of the time it will be partial volvulus cases are managed endoscopically.
Srikanth, to just an extension of what Dr. Lakshman said, majority of the volvulus that are corrected endoscopically are sigmoid volvulus. And especially in the elderly, you can potentially do repeat procedures at least 2 or 3 occasions before you think about surgical options because of their comorbidities and their debility. But gastric volvulus, I think one is not as rare as sigmoid volvulus, and as Lakshman sir said, only the chronic variety may be amenable for endoscopic derotation.
Dr. Absor has a question.
Another point, endoscopy, you are lucky to have the endoscopy done before CT scan, which in all the centers you may not get this.
Correct.
So laparotomy is the answer most often.
Correct.
And another thing is, when you have done endoscopy, there is another possibility. You can do decompression. You can suck out the air, which will give a partial relief to the patient also, if whatever possible. It may not be complete decompression, but partial decompression could be possible.
That was done, sir, and despite that, the patient didn't improve. Okay.
No, I know.
Yeah.
But that is a good option that we can do with the endoscopy.
Yeah. Nikita,
Yes,
continue,
sir.
ma.
Yes. So, patient had severe pulmonary compromise, and so we thought it was in best interest to electively ventilate the patient for 48 hours. She was hemodynamically unstable during the surgery and was started on noradrenaline, which was titrated to 10 ml per hour by the time we shifted her to ICU. Patient condition worsened overnight. She was hypotensive, had very high heart rate, and was in metabolic acidosis, and the demand for inotropes was increasing. So we decided for re-exploration almost 30 hours earlier than we planned. Upon removing the pack, we noticed that the almost entire stomach, significantly the greater curvature was gangrenous. So we had no other option but to do a subtotal gastrectomy, leaving behind only a small part of fundus which was viable. So this was the necrosed stomach, showing the greater curvature of the stomach. This is a
Pylorus.
pylorus.
Go to the next
Subtotal
picture.
gastrectomy was done.
Next, go to the next picture. You can show the yes.
This is the resected specimen of the stomach, showing the gangrenous symptoms.
I think there was one picture which showed the fundus stapled off. Is it the previous picture?
Previous one, yeah.
So this is probably the fundus stapled off.
No, that's the pylorus.
Pylorus.
No, this is pylorus. Here,
The pylorus, we have limited the number of pictures, and so probably that doesn't figure here. So this is the, this is the pylorus where this is the distal resection margin. We have not shown the picture of a proximal resection margin in the. Go to the next slide, Nikita, please. Yeah, instead, we've shown that there's a second laparostomy. Patient was unstable, so we didn't close the abdomen then also. Definitely didn't think about reconstruction, and this is the resected specimen.
Yes, sir.
Okay, carry on.
Yes, sir. The abdomen was left open for the second time.
Comments from others? Any better surgery? Anything else would have been done? Will you avoid a second laparostomy or do a definitive surgery?
Dr. Rajgopal, maybe you want to comment?
No, sir. Already when there's a gangrene like this, so obviously there is some more chances of definite wound infection here. Emergency exploration. So probably I don't think the plan was to do any re-look into the pylorus or proximal area. The plan was again quickly to come out of the severe sepsis and patient on noradrenaline drip. Yeah. That's all, sir.
Yeah. Nikita?
Yes, sir.
Some people may ask you on the first surgery, was there, if you had all the facilities, was there anything you would have done to maybe avoid, going in the second time?
Yes, sir. If only we could have option to check the vascularity of the stomach, sir, then
how?
By fluorescent methods.
Yeah. So if there is availability of ICG, indocyanine green fluorescent, check of the vascularity of the stomach. But again, in the middle of the night, it is difficult to find that. And I think instead of wasting time on on all these procedures, because it is very difficult and when the patient is very unstable. And again, I don't think anywhere in the world you will have these facilities available in the middle of the night. Good evening, Abhay Dalvi, sir. Very glad. Good evening.
I'm listening.
Very glad that you could join.
No, Shivram, I have promised, so I will always join.
Thank you, sir.
Any comments so far, sir, about the condition of the patient? And
no, I joined midway, so I don't know the entire history. Only thing I can say is fundic gangrene, when second exploration, you are trying to anastomose something, you should be very sure.
Correct.
Proximal diversion is the norm of any surgical this when you're not very sure. Now, where to divert it, esophagus or otherwise, was the decision to be taken by the surgeon on call. But otherwise, everything has gone on very nicely. Thank you.
Just for your information, I think about proximal 10 centimeters of the fundus was viable. So a staple was put across the fundus and a staple line was put across just before the pylorus. So that, and then the rest of the stomach was resected.
No, I'm not worried about the distal part. I'm worried about the
proximal. I agree. Yes, you are absolutely right.
See, look at the fundus. It is supplied by left gastric, right gastrocolic, all these. And then in spite, fundus is the most vascular supplied arterial supply.
Yeah.
And it looks to be viable. It looks in inverted commas.
Yes.
It should not be taken into account at all.
Yes, sir.
That is the way I would like to think about it, but it's okay.
Yeah. So,
okay.
Sir, Dalvesa Lakshman here. Good evening.
Yeah,
the
Lakshman.
fundus was available, and there was no ambiguity about it. So the fundus was left behind. So it was stapled off, as was the distal part, and the stomach in between was resected, sir.
Yeah, Lakshman, I believe in you, and I know you believe in me. So let us stop. She's doing a good job.
Yes.
Yeah.
Right. Now, any other questions?
Stomach is a highly vascularized organ.
Yeah.
First time it was congested. Then why should it go for gangrene?
No, I think the
condition should improve, no?
Correct. That is the thing. That is why, to give the stomach, as we said, as you said rightly, Srikanth, is a very vascular organ with multiple blood supply. So we thought when the stomach looked congested, it will improve given time. And
why should it go for gangrene?
That is one.
It should have stayed.
Second one is in a young patient, young lady, doing a total gastrectomy at the first instance would be quite, because it has significant morbidity, if not mortality, in a younger patient. So to avoid both of them, the reason for that is the volvulus had probably compromised the vascularity for a considerable period of time before intervention was done, before she sought intervention in the hospital, and hence the stomach did not recover its blood supply, and hence it went into gangrene.
The volvulus.
Yes, Dr. Lakshman. And then Mohan.
Volvulus causes a stoppage of the circulation because of the twist. The vessels undergo thrombosis, and if it is for a good length of time before it is detorted, then the thrombosis remains, and in spite of the high vascularity, if the thrombosis is significant in a good part of the blood supply, it undergoes gangrene.
Yeah. Mohan?
Yeah, a couple of additional points. One is probably the venous obstruction must have been very severe, number one. Number two, the inotropes would have made the vascularity worse because she was on inotropes intra-op and also post-op. That would have produced further vasoconstriction and therefore worsened the ischemia in the post-operative period.
Correct. I think as all postgraduates know, the inotropes, especially adrenaline, but also noradrenaline, causes significant splanchnic vasoconstriction to reroute the blood supply to the more vital organs like the heart, the kidney, and the brain. So splanchnic vasoconstriction is a feature, especially once the dose is high, then the alpha blockade goes into beta blockade as well, and that causes significant splanchnic vasoconstriction. Okay.
But one more thing to add,
yes, sir.
Particularly for the postgraduates, you have to give, taking this, whatever is said about this splanchnic circulation is agreed to, but vasoconstrictors are life-saving in this patient. So you have to give it. Do not hesitate to give it because of your worry about the vascularity of the visceral organs.
Correct.
Absolutely. I think that's a very valid point. There's no question of avoiding the inotropes.
Ravishankar, can I?
Yes,
yeah, Ravishankar?
Yes, sir.
No, I would like to add to one or two things that gastric pull-ups are done by ligating the left gastric artery, and left gastropiploic. The vein, it survives on just right gastropiploic and right gastric, and it goes up to the base of the tongue.
Correct.
Base of the tongue. So that means stomach is undoubtedly having a very rich submucosal plexus.
Correct.
So extensively vascular in spite of ligating left gastric and epiploic. But when it happens in a volvulus, as has been already, it is a twisting basically, completely twisting. So that is one of the reasons this has gone for a gangrene, as has been mentioned. And initially, even in a sigmoid volvulus, It so happened that venous congestion that causes first, the problem, and then ultimately it goes for arterial.
Correct.
So that is, I think, that has happened. Unfortunately, we'll put it that way. But otherwise, stomach is a very vast. Yes.
Correct. Nuli, sir, has that answered your question?
Yes, sir. Yes, sir. Yes, sir.
Yeah.
Thank you, sir.
Okay.
Thank you very much.
There is a question about diversion in the neck. Yeah, if I may answer that, Naz, patient had a Riles tube in position that was decompressing it, and as I said, there was absolutely no doubt about the viability of the fundal area of the stomach. Yes. And we were going to wait for her hemodynamic improvement, wait for her sepsis to get better, and then consider reconstruction fairly soon. And that's actually what happened, as Nikita will tell you.
Okay, continue, Nikita.
Yes, sir. Patient was shifted.
Move your picture. Go to the next slide.
Sir. Patient was shifted to ICU with BP being maintained by noradrenaline at the rate of 10 ml per hour, and there was a persistingly high heart rate. By next day, noradrenaline was gradually tapered, and by POD3, she was off the inotrope and was started on TPN. During the last 3 days, she was transfused with 4 units of PRBC and 6 units of fresh frozen plasma. She was under the antibiotic coverage, as I have mentioned.
Okay. Right. Now, there is a very good question from Dr. Sangamesh. Any postgraduates, Pavan or Indraja or Sanya, anybody can take this question, or even Nikita can answer this question. See, the TPN, when is it appropriate to start TPN in a patient? For example, patient you said has been having pain, abdomen for the last 7 to 8 days and very severe over the last 1 day with multiple episodes of vomiting. And now already 1 or 2 days have elapsed. So the nutrition is an issue. When will you start the nutrition? Nikita or anybody, any of the postgraduates, please.
Sir,
final year PG, come on, she's first year PG.
Yeah. Indraja or Pavan or even Sanya or anybody else, any postgraduate in the group, please.
I think Sashidhar, can you answer? Is there in the group? Any PG?
Any PG. Okay.
I think can I come in here?
Yes, sir.
I think Nikita can answer, even if she's a first year PG.
Yes,
Nikita,
yes, sir.
Just think, this was me or you. When would you like to have a TPN, especially after such a disastrous surgery?
So once the patient is hemodynamically stable, we can start the TPN, sir.
So now the patient is apparently hemodynamically stable. Would you like to start it? Say yes or no. Don't get afraid.
Yes, sir. Yes, sir. If she's off inotropes, I can start it, sir.
So that's exactly what she's trying to say. Examiners or moderators can come in.
Yes, sir. So see, for the benefit of all the postgraduates here, TPN is a extremely hygroscopic and it causes significant metabolic shift, which is quite deleterious to the body when the patient is in severe metabolic acidosis, hypotensive, and on inotropic support. So hence the first priority is to stabilize the patient, get their hemodynamic stability achieved, and then consider starting the TPN. So though the nutrition is extremely important, it should not be at the cost of patients general well-being. So the TPN was started appropriately on day 3 when the blood pressure was under control, metabolic acidosis was corrected, and the patient was more stable. So then you start the TPN, right?
There is no need to start early because there was no reconstruction was done.
Correct.
Ravi,
yes,
question.
Yes, sir.
Question. Yeah, go on. That's it. FJ,
Sudhir,
was an FJ considered? Yeah.
Sudhir, we will come to that next question, and I think your questions will be answered in the next few slides. Right, Mark? Carry on.
Yes, sir. As the patient was stable, we have taken up her for reconstruction surgery on POD4. On removal of the pack, we noticed that the remnant near the fundus was healthy. So a loop of jejunum was brought anticolic and was fashioned an end-to side anastomosis with using stapler to the fundus end of the remnant stomach. Later, a jejunostomy was done distal to the anastomosis in side-to-side manner using a stapler. And feeding jejunostomy was inserted into the efferent limb of jejunostomy and anchored to the anterior abdominal wall. A suction drain was placed in the subhepatic space. Abdomen was closed by standard technique.
Okay.
This was
So
the reconstruction.
this was the reconstructive procedure. Now,
Yes.
I would like to invite Professor Dalvi. Sir, what do you think of the reconstruction?
Yeah, I don't want to challenge the decision of the surgeon. I just want to ask her, what did she learn from a suction drain being placed after this anastomosis?
Okay. Nikita, would you like to answer that question? Why was a suction drain placed in the?
Why not a normal drain?
Nikita, what does a suction drain
To
do?
provide some negative pressure inside, sir.
You are trying to suck out the anastomosis through your suction drain, leading to another leak. What have you understood out of it? I'm asking you clinical acumen. I'm not challenging anything.
Oh, are you sure it was a suction drain, Nikita?
Yes, sir.
What was the suction drain? Can you elaborate?
Romovac suction drain, sir.
Romovac, what was the size of the drain that was put?
She wouldn't know it was number 16. She was not at surgery. The number 16 suction drain. Yeah.
No. I'm just trying to know whether she has understood the role of suction against normal drains. And these are important issues in surgery.
Any other postgraduate like to take that question from Professor Dalvi?
Professor Grushantappa is there. You have any comment?
Ravi Shankar?
Yes. Srivatsan sir, good evening.
Yeah. I was just listening. Very good discussion. A bad patient, no doubt. Everything has gone on well. And patient has come out of the sepsis and metabolic derangement. Only comment is, instead of a loop GJ and a jejunostomy, the alternative could be a roux-Y, gastrojejunal anastomosis and a nasojejunal feeding tube, avoiding percutaneous jejunostomy. Physiologically, a roux-Y would be a better option.
Dr. Lakshman
And
sir,
a nasojejunal feeding tube which goes into the roux loop across the anastomosis.
Is it superior to the present?
So the problem is there is a patient who is on the ventilator, possible pulmonary hypoplasia, passing a nasojejunal tube, and then that would potentially cause problems, I would think. Dr. Lakshman sir, would you like to take
I have two comments to make. The choice between, I'll have to mute somebody because there is a background. Yeah, the choice between roux-Y and loop jejunostomy is debatable. Some surgeons prefer a loop, others prefer a roux-Y. And the problem with a loop is that you may have reflux of bile into the stomach remnant, which can give you very severe alkaline esophagitis, but we have circumvented that by a side-to-side jejunostomy, a good 25-30 centimeters beyond the GJ, which prevents the reflux. I am personally not in favor of a nasojejunal feeding tube because in case the patient has a need for a long-term feeding, a tube going through the nose would be very, very uncomfortable. It also has various problems in the nasal cavity, in the back of the throat. It increases the chances of reflux. And so instead of having a long-term, potentially long-term nasogastric or nasojejunal feed, I would prefer a jejunostomy.
Yes. Okay. Hebsur sir and Gurushantapa sir, your comments.
No, I think so. What has been done is absolutely fine, sir. Regarding jejunostomy and gastrojejunostomy, every surgeon has their own way of doing things. And what you have done is absolutely fine. I don't think so there should be any doubt on the time of surgery. It looks fine, sir. No problem.
I just
I think I
mentioned
wanted
it
to
as
ask
an alternative.
PG,
Yeah.
what is the percentage of gastric necrosis in case of volvulus, this kind of diaphragmatic hernias?
Yeah, she'll come to that in the literature review, sir.
Okay, fine.
She'll come to that. We are now discussing the nuances, operating this one. She will come to the literature review later.
Fine, sir. No problem.
Ravi Shankar, I
Yes,
mentioned
yes, sir.
that as an alternative.
Absolutely. You are absolutely right.
No, I didn't say that this is not desirable. I said, as Lakshman mentioned, the reflex, alkaline reflex can be prevented. And, nowadays, all our surgical oncologists for major procedures have switched over after seeing me doing the nasojejunal feeding tube. For every case, even for a Whipple's, they put in a soft, small caliber nasojejunal tube, which doesn't hurt, the throat or produce reflux. So they're doing it as a routine for all their major cases. I mean, that is our experience. I'm sharing with you. And I have done this since probably 3 decades for all anesthesiologists.
I think,
continue.
I think there are, as surgeons, there are, as of now.
No, it's an option that I'm just.
Definitely a good option. Definitely a good option.
It's an option that I'm suggesting.
Yeah, Shivram, sir.
People can try it and see.
Ravi Shankar, I think we'll move on.
Yeah. Okay. Continue, ma.
Yes, sir. We started FJ feeds the next day and TPN was continued for 2 more days. As the ICD output gradually decreased, we removed it on POD 7. On the same day, the chest X-ray showed the collapse consolidation of entire left lung with moderate left pleural effusion. And patient was getting better symptomatically, but could not be weaned off the ventilator. So we had done tracheostomy in view of prolonged ventilation on POD 7. As the drain output decreased, we removed drain on POD 8 and we started giving her oral feeds. We even started TP's trial by POD 10. On post-operative day 12, in view of persistent tachypnea, pulmonologist was involved and he advised for a CT thorax, which revealed left pleural effusion and collapsed lung, with a collection of around 800 ml in the pleural effusion, in the pleural cavity. Which was not significant enough to cause the pulmonary compromise. However, we took a benefit of doubt and done an ICD insertion under the guidance of ultrasound and drained the 700 ml of fluid.
Yeah. Yes, Professor Dalvi, sir.
Dalvi wants to say something.
Yes, yes, sir.
Yes, Professor Dalvi.
Yeah. I just want to ask her, can we go back to the X-ray chest?
Previous slide.
Yeah.
Yes.
Yeah. What does it teach you?
Can you read the X-ray, Nikita?
Yes,
Nikita,
sir.
Yeah. What is this?
What do you see?
The chest X-ray of PA view, which showing the opacity, homogeneous opacity of the left lung, sir.
So what does it teach you? What does it tell you?
The lung did not expand well, sir, on the left side.
And can you see the upper border of that air fluid level?
Not clearly,
properly
sir.
In your X-ray? Can you see the upper border of the air fluid level in that X-ray? Does it tell you
No, sir.
whether it is consolidation or it is fluid? See, the problem
It looks
is,
like a consolidation, sir.
so consolidation, and radiologist tells you it is effusion. Whom do you believe?
A personal observation, sir.
The
So
combination
your
of
personal
both, right?
observation is it is consolidation. So you don't want to do anything. It has to improve on itself, right? What are the causes of consolidation post-operative?
Any of the
I
other
know
PGs?
I know you are only first year resident. I just want to wake you up from reality when you become a senior.
Maybe one of the other PGs can contribute.
Answer?
Please ask them.
Indraja or Pawan, what are the problems associated in the post-operative period which causes collapse consolidation of any particular lung?
Sir, pneumonia, sir, in day one atelectasis, and if we not
one minute, my dear, 1 minute. On one side.
Okay, sir.
If it is one side, what do you think?
No. My question is very clear. On one side, what are the causes? Can it be intra-abdominal cause? Hello?
Sir, I'm not sure, sir.
Correct. So whenever God has made a body.
Kindly educate them, sir. Kindly educate them, sir.
Yes. So when God has made a body, when pulmonary complications occur, if it is intra-abdominal, they're expected to be on both sides. When unilateral it happens, you got to look at why it is happening on a unilateral side. Then the whole thing goes on to looking at pneumonia, lung problem, or intra-abdominal left-sided problem giving rise to effusion on the other side. Now I would like to ask this person who wants to answer a question. What is your opinion?
Pawan, what do you think has happened?
Sir, left-sided pneumonia, sir.
Okay, fair enough. So you want to conserve and treat the patient, correct?
Yes, sir.
If you are not convinced that this is pneumonia, what is the investigation that you would do, maybe bedside, to know whether this is absolutely pneumonia or something else?
So X-ray chest, sir.
You've already done the X-ray chest,
That
man.
is
What on the bedside? What else will you do?
Something better.
Ultrasound, sir. Ultrasound.
Very good. Very good. Very good. So it shows you fluid. Now let's go to the next slide because 700 cc has been drained apparently.
Drained. Yeah.
Ravi, if I may come in.
Yes, sir.
Pulmonologist was involved on day 3 or 4. Okay,
Yes,
not as late as day 7 or day 8. And as she has explained, if you can just go back one slide, Nikita, please. That X-ray that we were talking about, yes. This was POD 7 and the ICD drain had become very less. And so we had removed the drain, but then when we took the X-ray, it was still a bit of a whiteout. But one thing that has not been mentioned so far is to look at the position of the trachea. It is central, which tells you that there isn't a huge effusion.
Correct.
And the differential at that time was a degree of hypoplasia with a consolidation of the remnant or the hypoplastic lung on the left side. Another thing that can give you a whiteout like this is pleural thickening. We're already on day 7. So if they had a degree of infection and effusion in reaction to that, there can be pleural thickening, which gives you a picture like this. In which case, we had a choice of doing an ultrasound, but the pulmonologist felt that to be on more solid ground that we should repeat the CT. All right.
Okay. So Lakshman, can I come in here?
Please.
Yeah, Lakshman, I am a great follower of yours, but I want to ask the candidate presenting the case, did he or she auscultate? Did the sonologist auscultate this patient? Let me know the findings.
Yeah, so the patient, Nikita was not there. She's just presenting the case, but
I know,
yes. at that
blame her.
point,
She-
yeah,
she's
at that
just
point
first
in
year.
at that point in time, the chest was auscultated, sir, and there was, there was no paucity of sounds or distant sounds to suggest that there's fluid, but there wasn't an obvious bronchial breathing as well. So the clinical contribution of auscultation at that point in time was limited, and that is
Fair
why
enough, sir. Fair
that is
enough.
why they
Fair-
asked for a
fair
CT.
enough, sir. Fair enough, sir. I'm just going to say, just to the PGs who are listening, that clinical examination and reading of an X-ray is extremely important.
Correct.
That's my take. Thank you.
Absolutely, sir. Absolutely. Your point is well taken, sir.
I joined late, Ravi Shankar.
Yes, yes, sir.
Just want to know whether the diaphragmatic hernia.
Srivatsa, one sec. There seems to be some big background noise. So could you just attend to that, please, and then speak? Thank you. Yeah.
Lakshman sir.
Please unmute and speak, Srivatsa. I just was pointing out the background here. Please.
Yeah, whether the volvulus stomach had occupied the left pleural space and
Completely,
displaced the
yes.
left lung.
Yes, completely.
Was that the reason as to why the left lung was affected with the, ischemic segment of the stomach occupying that area, in addition to hypoplasia? Because I don't know whether there was a hypoplasia or not.
Sir, the one of the theories is that lung hypoplasia is primarily the reason for the left, the pleuroperitoneal canal being open.
No,
and
I joined late, I told you, so I don't know the history. Maybe it is a primary diaphragmatic hernia. Yeah, when you say that, it is
it was a primary diaphragmatic hernia with gastric volvulus of the stomach inside the thoracic cavity.
Okay, so both reasons for the lung going into a pneumonia.
Ravi Shankar, we have to move on.
Yes, yes. Carry on, ma.
Yes, sir. So tracheostomy was decannulated and post-operative within 13, and as ICD output was decreased, the second one was also removed on POD 17. However, her oxygen demand came down gradually, and she was off the ventilator, but she was still tachycardic and had fever spikes. Her sputum culture showed yeast cells, so we started her on antifungal medication. On POD day 20, chest X-ray showed, even then, the chest X-ray showed no adequate lung expansion. So we have gotten CECT done of thorax and abdomen, which showed left pulmonary consolidation, regression of left pleural effusion, and left hemithoracic volume reduction. We were in dilemma whether it was a collapse consolidation or lung hypoplasia. Anyway, we went ahead and gave aggressive physiotherapy, incentive spirometry, and other supportive measures. She started improving well, ambulating comfortably, taking oral feeds along with FJ feeds, moving bowel regularly. So she was discharged on POD 27 with IV antibiotics. On follow-up in OPD, initially she was seen once in a month for 3 months, and then once in 3 months. She's doing well. She's taking small meals frequently. She's on dietary supplements. She's putting on weight, and even her exercise capacity has been gradually improving. There is no limitation in activity. It's been almost 8 months since the surgery.
Good. I think that is so it is a very happy ending of the patient. I think the most important things you have actually stressed in the post-operative period, the exercise tolerance improving, and one of the major problems after total or subtotal gastrectomy is failure to thrive and significant loss of weight. It's very heartening to know that there is weight gain in this patient. Other thing, I would like to stress to the postgraduates here that you saw that there was a nice transition between the TPN and the FJ, feeding jejunostomy feeds. It is important that TPN usually should be given for a minimum period of 5 days for it to be effective, and there should be a gradual transition from TPN to feeding, enteral feeds, because otherwise it will cause significant hemodynamic and also metabolic disturbances, electrolyte disturbances. So it is again for postgraduates to know that this transition has to happen gradually. So I think all of these things have been managed well. Kurshantappa sir.
Yeah, Ravi Shankar.
Good evening, sir.
Yeah, good evening. Good evening. All of us are mentioning Nikita is a first year PG. I really appreciate her the way she has presented the case.
Thank you, sir.
And I really appreciate the team of people who are involved in the treatment of this case, both surgical and post-op management. I think good knowledge and the patience and planning the treatment in sequences probably has helped this lucky patient under a good team, because ultimately the outcomes are really excellent, even though it has taken almost 2-3 months. So the outcomes are excellent.
Thank you, sir.
One or two points about that X-ray what Lakshman sir mentioned. Yeah, we want to know from the postgraduates like a theoretical explanation of what are the causes. At the same time, in a given case, we should be in a position to explain that particular X-ray. What Lakshman sir has mentioned, the points of haziness in the hemithorax. To those points, my one more point to added was just to check their lateral thinking in postgraduates. Was the X-ray taken in supine position? So even unknowingly, because the patient on ventilator, not able to stand, if you take the supine film, even with a fluid there, with little bit of inflammation in the parietal pleura, whole hemithorax looks hazy, indicating that there is no absolutely working lung on that particular side.
Yes, sir.
So here we take it granted that probably the patient like not in supine, it is erect film. But they should keep that also in mind just to have check their knowledge.
Yeah.
And
Right.
second, invariably these people have a hypoplasia. Yes, we can have these findings. Otherwise, Ravi Shankar, it is a nice case and a lucky person to have treated with a team.
Yes. So go to the literature review, Nikita. Go forward. Go forward.
Which picture, sir?
No, literature review. That is,
Literature.
Go to the literature review,
Okay,
Nikita.
sir.
We're done with the case presentation. Yeah, go on. Yeah.
Sir, gastric volvulus is defined as abnormal rotation of stomach. It's a rare condition. It's most common in pediatric age groups and usually in adults older than 50 years of age. It can be classified into organoaxial and bicentroaxial depending upon the axis of rotation. 30% of the cases occur as a primary event, but it's more commonly secondary to the other causes. There is 5 to 28% of chance of necrosis of gastric volvulus. If necrosis is present, then the mortality rate is 30 to 50%, which is very high. Emergency exploration is required, and if vascularity is compromised, subtotal or total gastrectomy is required according to the extent of gangrene. When no resection is done, the stomach is fixed either by anterior gastroplexy, lateral, or diaphragmatic fixation. Congenital diaphragmatic hernia has the incidence of 0.8 to 5 in every 1,000 births. Delayed presentation in adult diaphragmatic hernia, there is an incidence of 0.17 to 6% of the total diaphragmatic hernias. It is of generally two types: the left posterior lateral Bogdalex hernia and the right sternocostal Morgagnis hernia. Treatment is definitive treatment is by surgical exploration, primary closure, and if required, mesh repair. One of the complications in the case of congenital diaphragmatic hernias is lung hypoplasia. During the embryonic development, due to the compression of the intestinal contents in the left thoracic cavity, the development of airway is compromised, which results in abnormal vasculature and abnormal growth of airway. It results in persistent pulmonary hypertension. In few cases, left ventricular hypoplasia and dysfunction is also noted. There is another hypothesis which states that pulmonary hypoplasia is the primary causal factor for the congenital diaphragmatic hernia. One of the most important point in our case, which we noted, was that how to differentiate a consolidation versus a hypoplasia. In a hypoplastic lung, in hypoplastic lung case, the contralateral lung, it shows hypoplasia, and the patient has recurrent infections due to hypoplasia, and there's a history of dyspnea upon minor exertions. Damage control surgery is a concept of abbreviated laparotomy designed to prioritize the physiological recovery and over anatomical reconstruction in a seriously injured or compromised patient. Absolute indications of damage control surgery are base deficit greater than 8 milliequivalents per liter, metabolic acidosis, hypotension, hypothermia, and coagulopathies. There are 3 phases of damage control surgery. The initial phase is aimed for the primary management of the patient, which is most commonly stopping hemorrhage in case of traumas and control of infection. The second phase is resuscitation, in which the patient is monitored in intensive care unit and decision is made whether to go for the definitive care early or as planned. And the final stage, which involves the definitive surgical intervention. Thank you.
Well done. I think now.
Excellent.
So let us.
Kudos, sir. Kudos to the managing team considering mortality of 30 to 50% in those with gangrene, and very well presented. Lot of learning points also. Thank you.
Nikita, I can stop sharing.
Sharing. Shivram sir, your comments.
Excellent. I think till the last moment, everybody was thinking this patient will not survive. But as everybody said, the teamwork of the entire surgical team, ICU team, and the pulmonology, everybody has worked very hard, including the nutritionist. I think that's what has done miracle in this patient. Excellent managed, and also discussion was excellent. Very good. I think it was a very appropriate case to bring to this forum. Yes, Dr. Mohan.
Mohan.
Just to add on, I think, of course, it's a very challenging case, very well managed. But one point I'd like to stress is the post-operative care which was given to this patient in the immediately after the first surgery. They picked up the fact that the patient was worsening, and they went in ahead of what was actually planned. I think that saved the patient, because if they had waited, they probably would have lost the patient with such a large amount of gangrene in the stomach. So I think what the stress here is, or what the PGs have to learn, is that when there is a sick patient, they should literally sit with that patient in the post-operative period. It is not enough if the intensivist or somebody else or the anesthetist is there. The surgery PG has to monitor and ensure that things are going on smoothly. If there is a doubt, call their seniors and take an opinion, because re-exploration is something which the surgeon has to decide. And it is based on your clinical findings and the other parameters. So this is an important learning point as well.
Correct. Nikita, there is a question in the chat box. How do you measure intra-abdominal pressure when the patient is in the ICU? Do you know?
I'm not sure, sir, but I think abdominal girth can be get in correlation, sir.
That is one, but it's not very exact. But there is a better method. There is already something that you have inserted already to the patient. You can use that. I have given you a clue.
Feeding jejunostomy, sir. Through
No. Feeding jejunostomy cannot. But there is something you have inserted.
Riles tube, sir.
Lower abdomen.
Go to lower.
What other tubes are there, Nikita?
Police catheter, sir.
Thank you. That's right. You're right.
So
the bladder reflects the intra-abdominal pressure, Nikita. So if you can have a transducer on your bladder, on your full-use catheter, you will get an intra-abdominal pressure.
So you will monitor the abdominal compartment syndrome. Akshat, does that answer your question? Akshat, are you there?
Ravi Shankar.
Yes, sir.
Very well moderated, nicely done. Only one question that I have to the presenter. What is the reason for yeast cells which were grown? Was it from culture or from the lung? I mean, what is the reason that they grew yeast cells, and what is its significance?
Yes, Nikita, would you like to answer that question?
Yes, sir. As the patient was on ventilator and there was a morbid surgery which she had undergone, she was immune compromised, sir, and yeast fungus infections are mostly opportunistic infections. So that would have led to the yeast cells in the culture, sir.
Correct. Dalvi, sir, your final comments. Sir, please unmute yourself. Abhay Dalvi, sir.
Yeah. I just want to ask Nikita one question.
Yes, sir.
As a first year houseman, first 6 months, you are excellent, dedicated to a patient. I'm happy with you. Tell me only one thing.
ಏನು ಮಾಡಿಲ್ಲ ಕೇಸ್ಗಳು
Will you go ahead with clinical examination and diagnosis versus investigation reports that come in your lab?
Nikita, answer that question.
Clinical examination is of primary importance, sir. Lab investigations are just to support or help in the process of diagnosis, sir.
Very good. Come and join me sometime in Mumbai.
Nikita, hello.
Yeah,
We want to keep her here in Bangalore, sir.
Hello, Nikita.
Dr. Shafi.
Yes, sir.
Yeah,
Good evening,
nice
sir.
to see you.
No. This is out of the subject discussion. I just want to ask Nikita, where you did your UG?
Sir,
No,
Usmania
Nikita
Medical
is in
College,
demand.
Hyderabad, sir.
The basic is very strong, and you are presented very well like a consultant, and your response is answering the way you are answering also good.
Excellent guidance from Lakshman and Ravi Shankar.
Yes, they are in a good hand. Good person.
Ravi Guru Shantappa sir has his hands up, please.
Sir, Guru Shantappa, sir.
Yeah. Just I wanted to know how long the feeding jejunostomy was there, Nikita? How long? Total duration of feeding jejunostomy?
Sir, I think by the time she came for second review.
Tell me the duration after it is being done and started on feeds. How long? In the follow-up also she had feeding jejunostomy when she was discharged?
Yes, sir.
She didn't follow up in the OPD, sir, but yes, it was on for a total of 6 weeks, sir.
6 weeks. Yeah. Nikita, any schedule was done for feeding jejunostomy? Any enteral feeding schedule? Anything? You have any idea about?
Yes, sir. A feeding schedule was made, and what all feeds which were advised by the nutritionist were given in a printed form to the patient and attender, sir, which included.
Yeah, tell me.
Which included high protein diet and liquid diet, sir, mostly.
Okay, yeah, just for the postgraduates, because we are talking about TPN, but if the question is asked, what is the best nutrition in a surgical situation? Still, it is a enteral nutrition. Okay, there are few things as a PG you should know. In enteral nutrition, what is the minimum length of the GA tract? That is a small bowel required to have an effective enteral nutrition. Either it is a oral, tube, or feeding jejunostomy, whatever it is. You should know what is the minimum length required. Second, you said the nutritionist has given the schedule for feeding jejunostomy. In that, as a PG, like TPN, you know what is the composition of TPN. Like that, even a enteral nutrition also should have all the 3 components of that, including the elements. Second. Third, you should be knowing what are the routine elements or routine diet the person takes. Out of that, you should tell them to prepare the diet so that it can be fed through the tube. So do these things little bit of, once you do well in the remaining presentation, probably somebody may ask about these things. What are the components of enteral nutrition? What are the routine daily, the items, what do you use for preparing the diet? Or how you advise them once they go home, how it should be fed, like what are the using routine items. So that also should be advised to the patient so that it will help. And what is the minimum length required? How long? What are the difference between a TPN and enteral feeding? So this is for all the postgraduates to look into. And once you do well, these questions will be asked.
Thank you. Dr. Rajgopal Shanai, any final comments?
Final comments, sir?
Nothing, sir. Firstly, congratulations to Dr. Nikita because so clear, lucid presentation, bold presentation, and very nice presentation. Definitely, it will help you. Secondly, as has been everyone has said, as a postgraduate, you know that early exploration, which Dr. Ellen Mohan mentioned, what you expect is a PG to realize that, importantly, patient is tachypneic, patient has got tachycardia, patient has got temperature, and patient has got tenderness. you have to pick up it very fast. Intra-abdominal sepsis, one of the organs which go failure very early is renal failure. This is one other thing you should remember. This patient has a complication of a lung also, but in addition, sepsis. If you in retrospectively, patient has a saturation of 93%, correct? When a patient came to the hospital. The patient was definitely in early sepsis. There's no doubt about that part. Correct. But only issue was about the exploration, which has been already clarified in between. So very well managed. And other thing is that the feeding jejunostomy, yes, no doubt. When in doubt, you do a tube feeding jejunostomy, especially upper abdominal pathology, because you can feed well and you can keep the tube for a longer period. Only one or two questions to Nikita now. Any complications of feeding jejunostomy?
So fistula formation, sir, and
fistula. Why? Okay. Yes. Anything else? Fistula. Anything else?
Leak from the site of insertion, sir.
So that is why you have made you have grid cells. Other one is what is the other one type?
Stricture formation.
Not stricture.
On late complications, stricture formation.
Intersusception also can happen. Intersusception. So you have to keep it in mind. Feeding jejunostomy also has its own complication, as been already mentioned. But you have to be aware of these possibilities in this. Sir, that's all the comments. Well done, sir, and Dr. Lakshman and the entire team and management. Young lady, unfortunate that she has to lose her stomach. What to do?
But she survived, sir. But she survived.
Yeah. Thank you, everybody.
Yeah. I just want to ask her one question. I came in only because Raj came in. Talk about jejunostomy feeds and you discharge a patient. How would you educate the relative?
Nikita, you want to take up?
You take that. So she may not know that, sir.
Yeah.
So I think. See,
I think that's the first thing that first poster should know. It's okay. If she doesn't know, all well with her, no problem. She's still good.
Yes, sir.
See, Ravi, if I may.
Yes, sir.
Because I may not get the chance at the end, I would like to thank KSASI and the EC for giving us this opportunity. Congratulate yourself and Dr. Mohan for your excellent moderation, and thank all the seniors who gave in such very good inputs, the learning for all of us in this, and I'm very grateful to them. And finally, a big thank you to my team. This cannot, all of you stressed it as well, this could not have happened without the team working round the clock to help the patient. Particular mention of Nishant, who works with me very closely, and our ICU team, the nutritionist and the pulmonologist. And of course, the nurses in our hospital who put their every effort to make sure that this young lady got better. And we were lucky to get away with a difficult issue. Thank you all of you once again. Thank you.
Sir, I'd like to disagree with you, sir. There is no question of you got away with it, because you actually worked and you made it happen. So you didn't get away with it. You actually planned it and made it happen. So congratulations to the entire team. I think just the feeding jejunostomy, I think the main thing is there are two unphysiological, which is you feed through the 24 hours, at a rate of 50 to 100 ml, and then as the patient orally, patient is taking orally, you can start reducing, and then you can go for a overnight feeding. You start the feeds at maybe at 10 o'clock at night and through the night, and then during the day you stop it and allow the patient to feed, and then gradually taper the number of hours that you give, that as the patient is improving and the weight is improving and you are able to manage and maintain the nutritional requirements, then you can gradually taper it off and stop it. So that is how usually it is done. So this is for the information for the postgraduates. The important points to stress to the postgraduates again is to management of the jejunostomy feed. You have to flush the tube with water after every feed so that it doesn't get blocked. That is one of the complications of jejunostomy feed. If it gets blocked, then it can be a problem. So after every feed, you have to flush it with water. Sometimes if the flush is difficult, then you can use soda or this one Sprite or whatever, Coca-Cola or whatever, aerated water to flush the tube. So that is about the care of jejunostomy feed. Mohan, your final comments?
Just that if somebody is asked complications of jejunostomy, to classify the answer, it may be because of the technical reasons or because of the feeding, because hyperosmolar feeds can also produce diarrhea and other problems. So that could be another complication which the PGs have to watch out for, especially if there is a large volume which is given suddenly. Otherwise, I would like to congratulate Nikita again. She's done a wonderful presentation. And congrats to Dr. Lakshman and his team for a very good management. Thanks to KCSI and the committee for giving us this opportunity. Thank you, Ravi.
Yeah, final words to Dr. Shivram and then Dr. Chandrasekhar.
Thank you, everybody. I think we had a very good discussion and also an excellent case. And one question to Ravi or Dr. Lakshman: which tube you use for feeding jejunostomy? What tube?
I just use the right tube, number 14.
Anybody using T tube? We use T tube. It works very well. And also
you can use T tube also. Yeah.
We use T tube, sir.
T tube, right. And
I use the Riles tubes.
Nowadays, T tubes are not used for biliary, but it's most used for
Feeding jejunostomy.
Feeding jejunostomy. Yeah. Thank you very much. I think excellent, Nikita. Excellent, very nice.
Thank you, sir.
She had been with us for a trekking. I know her very well. She's a very sportive girl, and with Dr. Lakshman's guidance and all, she's doing very well. We had very good future. You are already in demand. All the best to you. Dr. Mohan and Dr. Ravi Shankar, excellent moderation and excellent case. And this is how the morbidity case should be discussed. Dr. Rajgopal Shanai wants to say something, I think, then we'll stop. Otherwise, yes, Chandru, to you.
Yes, sir. Thank you, everyone. This was an excellent presentation and moderation by our moderators and an excellent discussion on the case. What the basic lesson, what we learned is early recognition, early intervention saves, even you have a major mortality, we can save the patient. That is what is the need of the hour. So thank you very much. Thank you, everyone. Once again, thank you.
Yes. Good night.
Thank you. Good night.
Good night, sir. Good night.
Good night.
Good night. Thank you. Thank you.
Night, sir.
Good night.
Absolutely, sir.
Chandru. Shivram sir reply ಮಾಡಿಲ್ಲ ನಂಗಿನ್ನ.
ಶಿವರಾಮ್ ಸರ್ ಇದ್ದೀರಿ? ಅದು ಮೆಟಲ್ ನ್ಯೂಸ್ ನೋಡಿದ್ರಾ?
ನೋಡಿಲ್ಲ ರೀ, ಇವತ್ತು ಬಿಸಿ ಇತ್ತು. ಐ ವಿಲ್